Now, this is really a very big deal. So you put a little magnet in the largest positive lymph node. You give the patients 2 cycles of low-dose ipilimumab plus high-dose nivolumab, 3 milligrams per kg. 60% have in only that index lymph node with the magnet a pathologic complete response or a pathologic near complete response. And then we don't do any lymph node dissection anymore. There is no more mutilating surgery. And you will see that those patients, almost all of them, are cured. My talk goes with a specific interest primarily in the variety of skin cancers, but the translation into a number of other tumor types of the neoadjuvant immunotherapy revolution. And it leads to a complete paradigm change, which is most visible in the skin cancers and in rectal cancers, and also is going to be quite visible in bladder cancer. And it is not surgery first. No. It is immunotherapy first, and then surgery only if still necessary. And this paradigm change goes into multiple tumor types and will change our whole approach and way of thinking about how we treat cancer. And so these are my disclosures. And we have the main players. It's anti-CTLA-4 and anti-PD-1. They got the Nobel Prize in 2018, and anti-LAG-3 for the guidance of the T-cell immune therapy system for optimal results. And so in melanoma, we saw that there were approvals for anti-CTLA-4, for anti-PD-1, and for the BRAF-MEK combination for BRAF mutant melanomas for adjuvant therapy, because clear impact on relapse-free and distant metastasis-free survival, but not on overall survival, because the treatments, once you have distant metastatic disease, that are available are so effective that they close the gap if you were in the placebo arms of the adjuvant trials. So the overall survival benefit is not there, or it's only marginal. So then the question is, how come? And actually it is because we did lymph node dissections in patients with positive lymph nodes. And so these are the 4 trials: adjuvant ipilimumab, adjuvant nivolumab, randomized in these trials against ipilimumab placebo with an impact on relapse-free survival, and on distant metastasis-free survival, and on overall survival. It's the only trial with an overall survival benefit because there was no access yet to anti-PD-1. That's how early the trial was conducted. Nivolumab versus ipilimumab. Well, both anti-PD-1 and anti-CTLA-4 were available, and there was no overall survival benefit. The BRAF-MEK, no overall survival benefit in the BRAF mutant melanoma patients. And the pembrolizumab versus placebo trial, I will show you a slide. As you can see, I've been very active in my life with adjuvant trials in melanoma. So this was the first trial, which I still have to show because it's an important 3 curves at the top. It shows you that the impact on relapse-free survival with adjuvant ipilimumab, anti-CTLA-4, for relapse-free survival, for distant metastasis-free survival, and overall survival is exactly the same and happens to be significant. But this trial was conducted at the time where if you were in the placebo arm and you relapsed, you didn't get access to ipilimumab, you didn't get access to anti-PD-1, because there were no approvals yet for the DMFS relapses, and so it was maintained the benefit. This trial is pembrolizumab, the top curve, randomized against placebo, the bottom curve. But in this trial, there was systematic access to pembrolizumab in case you relapsed. And so that was to see if there would still be a benefit by giving everybody adjuvant therapy. Well, you see that the top curves for RFS and DMFS, as expected, are with pembrolizumab, but the PFS2 endpoint is the endpoint where you were a placebo patient and then you relapsed and then you got anti-PD-1. You see a response rate of 40% and you pick up the benefit and the curves get a lot closer together. Whether this will still benefit in terms of overall survival, we will know next year when we will report the 10-year results. But we already know from real-world data in the Netherlands and Sweden that when you took the time frame prior to adjuvant therapies with anti-PD-1 or BRAF/MEK and the time frame when they were approved, there was no, in the population real-world data sets, a benefit for adjuvant therapy, meaning that the impact of just adjuvant therapy in stage 3, lymph node positive melanoma, is very marginal or absent. And there was just a report from the United Kingdom where the benefit was just a couple of percentage, which happened to just hit the p-value for significance. So, but it's marginal or absent. So if you do surgery first, that means your lymph node dissection, you are left as a patient only with minimal residual disease. And this is insufficient for the immune system with anti-PD-1 and anti-CTLA-4 to work with, because minimal residual disease has very few T cells inside minimal residual disease that can be expanded with anti-PD-1 and activated and so on. And so we see also multiple failures of anti-PD-1 plus anti-CTLA-4 or with anti-LAG3 or with anti-TIGIT. All those trials failed in the adjuvant setting where you did a lymph node dissection. Why is that? The T cells go to school in the lymph nodes where you have metastatic disease. And the anti-CTLA-4 gives you a course intensification in T cell priming. So you increase the number of successful pupils who will go out into the body to kill T cells. So you get more and more diverse T cell armies if you have not done your lymph node dissection. And that means that the neoadjuvant immunotherapy is the correct paradigm, because that means you first use the instructive potential of primary tumors and lymph node metastases to optimize your immune system function to be successful. And the differences are simply sensational. So this I'm going to skip. Sorry. So there is a triple benefit with neoadjuvant immunotherapy. It will lead, and I will show this, in melanoma to more cures, shorter treatments, because you only need a couple of induction cycles, and less surgery. 3 benefits, a triple benefit. And this is the hallmark paper that everybody should read to understand why neoadjuvant immunotherapy is completely new paradigm. Look at the top 10 patients in red that were randomized against the top 10 patients in blue. And what did they get? They had palpable lymph nodes, melanoma, and they were either operated first. Adjuvant therapy was 2 cycles of anti-CTLA-4 and anti-PD-1. Or they got into the neoadjuvant arm, they get 2 cycles of anti-PD-1 plus anti-CTLA-4, and then they get the surgery, the lymph node dissection. At the bottom in the left corner, you see what happens to the number and the diversity of T cell clones as detected in the PBMC with these different regimens. In red, you see the number of specific T cell clones that were already present at the beginning, and in dark red, the expansion of the T cell clones. In blue, you see the neoadjuvant effect, and it's a double effect. You get more different and bigger armies of T cell clones that already are present at the beginning. But look at the dark blue columns. That's all newly created T cell clones. And that shows also that the amplitude of all those T cell armies is bigger than before or is totally new. What's the result? The result of neoadjuvant therapy, immunotherapy, is you get more different and diversified T cell armies that each in size are bigger than you can ever get in the adjuvant setting. And this is a recipe for cure because that's how you win a war. And so they did then 64 patients with neoadjuvant anti-CTLA-4, anti-PD-1 with palpable lymph nodes in melanoma. The green curves are the patients who had a major pathologic response. That's either a pathologic complete response, that was 60% plus 15% near complete response. You see that these patients are basically cured. They do not relapse anymore. And so we have never, ever in the history of melanoma seen these kind of curves. So that's the first promise, more cures with neoadjuvant immunotherapy. Then you can say, well, for BRAF mutant melanomas, perhaps you could achieve the same thing with a BRAF MEK inhibitor combination. Here, these are slides about pooled analysis between Amsterdam, Rotterdam, Australia, MD Anderson, Philadelphia, about patients who have a BRAF mutant melanoma, and they either got, as you can see now, anti-PD-1 based neoadjuvant immunotherapy, and you see all the responders do fantastically. They don't relapse anymore, and only the non-responders, they need something totally different, and they have the old curves of they're going to die. Now, these patients had the option to get a BRAF MEK inhibitor combo. And look what it does. It's not comparable at all to neoadjuvant immunotherapy. Only if you had a pathologic complete response do you have some benefit. But if you have less than that, a near complete or a partial response or no response, you have no benefit at all of your BRAF MEK inhibitor combination. So in melanoma, all patients, whether you are BRAF mutant or BRAF wild type, there's only one first choice, and it's anti-PD-1 based immunotherapy, and the efficacy is even bigger if you give it in combination with anti-CTLA-4. And these are all the patients who got neoadjuvant anti-PD-1 based therapy. The bottom curve is just anti-PD-1. The top curve is the combination of anti-PD-1 plus anti-CTLA-4. And it makes sense because you get a greater diversity of T cell clones if you add anti-CTLA-4. So what did they do? In the United States, the SWOG cooperative group did a trial in macroscopic, so stage 3 macroscopic lymph node positive patients and in resected stage 4 patients. They got, and that's the bottom curve, all standard anti-PD-1 after surgery for a year. Or, and this is the blue curve, they got only the first 3 doses of pembrolizumab, anti-PD-1, prior to the surgery. Look at the enormous difference by just giving 3 doses of anti-PD-1 prior to the surgery. And so this became rapidly standard of care in practice in a number of countries. Okay, so that's one observation. Now, they gave updates, and it's good for RFS or event-free survival. It's good for overall survival. and this just needs more follow-up to get the p-value. Can you improve on this phenomenon? Yes, you can improve on this phenomenon by adding anti-CTLA-4. Why? You diversify the schooling moment in the lymph nodes of your T-cell priming program with anti-CTLA-4, and you further expand with anti-PD-1. So the bottom curve in macroscopic lymph node positive melanoma is your standard adjuvant therapy for 1 year with anti-PD-1. That's the bottom curve. That's already better than what we used to do in the past, which was nothing. But look at the enormous difference by just giving 2 cycles of anti-PD-1 plus anti-CTLA-4 prior to the planned lymph node dissection. This is RFS, this is DMFS. So that is a more than 20% gain in DMFS at 18 months. And it's also true for at 2 years, more than 20% gain at 2 years for event-free survival and distant metastasis-free survival. So we have now reached our new standard approach for patients with macroscopic lymph node positive melanomas. Do we have an alternative? Yes, it's actually the combination of anti-PD-1 plus anti-LAG-3. Look at the top curves and look at the bottom curves. The top curves are the combination of anti-PD-1 plus anti-LAG-3. These are a series from MD Anderson. And look at the overall survival at the bottom. They don't die. They don't relapse. They are cured with just 2 courses of anti-PD-1 plus anti-LAG-3. The third promise was less surgery. Now, this is really a very big deal. So look at this slide. It was the Prado trial by Christian Blank in Amsterdam. Look at the slide at the left bottom corner. You see lymph node marker placement. So you put a little magnet in the largest positive lymph node. You give the patients 2 cycles of low-dose ipilimumab, 1 milligram per kg, plus high-dose nivolumab, 3 milligrams per kg. And then go to the top yellow box. 60% have in only that index lymph node with the magnet a pathologic complete response or a pathologic near complete response. And then we don't do any lymph node dissection anymore. There is no more mutilating surgery. And there is no more further adjuvant therapy. So there's not a full year of adjuvant therapy. It is just follow-up. And you will see that those patients, almost all of them, are cured. So this is the next promise. It's not only more cures, it's not only shorter treatments, because you don't need 60% of patients don't need adjuvant therapy anymore for a whole year, and they don't need surgery. So these are the 5-year data of this Prado trial. And look at the bottom curves. The top curves are the green one who have a pathologic complete or near complete response. They had no further surgery and they had no further adjuvant therapy. And you see almost nobody relapses or dies. We have never ever seen anything like it in melanoma. And we can cure about 60% of patients with just 2 cycles of anti-CTLA-4 plus anti-PD-1 given prior to a planned lymph node dissection, which we don't do anymore because the index node had a pathologic complete or near complete response. So there you go. That's the new melanoma world. Now we have another tumor, cutaneous squamous cell cancer, that has a very high tumor mutational burden rate. And so they are loaded with T cells. So again, here, if you can avoid excision, then, but you give immunotherapy, you would be able to achieve great things. So it was Neil Groats from the MD Anderson who started this experience with the large, out-of-control cutaneous squamous cell cancers. And he didn't do disaster surgery for these enormous lesions, he gave them neoadjuvant anti-PD-1. Now look what happens. Almost 2 out of 3 patients had a pathologic complete or near complete response. And during the course of this study, more and more patients who were seeing this sensational response rate of these very large tumors said, whoa, wait a minute, I don't want any planned surgery anymore. I will sit it out and see if I can get simply a pathologic complete response. So again, more cures, shorter treatments, less surgery. So I give you here an example. This happens to be a patient in Hamburg in Germany. The man is 90 years old. He has a cutaneous squamous cell cancer. He gets 3 doses of cemiplimab, anti-PD-1. Look at that. A pathologic complete response. He never had surgery for this cutaneous squamous cell cancer. And now he's 4 years later, he's alive. Oh yeah, he also had 3 palpable lymph nodes, and they also completely disappeared and never relapsed. So there are trials ongoing where the top curves are the responders, the bottom curves are the non-responders, to look at the neoadjuvant approval of, in this case, cemiplimab anti-PD-1 for cutaneous squamous cell cancers. This is the new development. You can see that if you have cutaneous squamous cell cancers in the face or here on the scalp, and now you have a subcutaneous delivery module of anti-PD-1 for all 3 anti-PD-1s, why don't you just inject locally with anti-PD-1? Why do you want surgery in your face? Actually, nobody wants surgery in your face. And so you can see that the next revolution will be that for cutaneous squamous cell cancers, surgery for more than 80–85% will disappear because patients will just demand an intralesional injection with anti-PD-1. How about Merkel cell carcinoma, a rare tumor, but very high tumor mutational burden? Well, let me show you neoadjuvant results from Hopkins, from Susan Topalian. Look at the top curve. If you have a major pathologic response, you basically don't relapse anymore. Look at this patient, very interesting. Merkel cell tumor. Look at the right side. You see that the tumor has eaten away the skull all the way to the dura mater. So this man, for whom they planned very extensive reconstructive surgery and all this, he said, no, I don't want surgery. He gets a single dose of anti-PD-1. Look at the middle picture. He has a complete response with reconstruction by wound healing of his skull, and his ctDNA, which was vastly positive, and 6 palpable lymph nodes in his head and neck area, they all disappeared, and he was actually cured with 1 dose anti-PD-1, because it's not surgery first, it is anti-PD-1 first, and then surgery if still needed. So here is your paradigm change, and it's going to change our world. So in Amsterdam, we did a neoadjuvant immunotherapy for head and neck squamous cell cancers. This is just to show that if you give the combo of anti-CTLA-4 plus anti-PD-1, you get better results than with anti-PD-1 alone in the head and neck area. And this happens to be the FDA approval because there was a 22 months benefit in event-free survival by, again, changing your pembrolizumab dosing into also perioperative, so neoadjuvant dosing, and then completing the full year of adjuvant pembrolizumab. So the perioperative for head and neck cancers is now standard of care. What about triple-negative breast cancer? Well, triple-negative breast cancer, well, here you go. This is the second publication by Peter Schmidt. So showing that there is even in this pathology an overall survival benefit by adding anti-PD-1 into a perioperative modus. Preoperative, you get a higher pathologic complete response rate of your primary lesions in the breast, and you see less relapses and an overall survival benefit. But here, this is actually, so we'll get an update of this at ESMO later this year. This is what, Miriam Chalabi from the rectal cancers, it was already discussed. But together with Marleen Kokke in Amsterdam, they started neoadjuvant combo immunotherapy in triple-negative cancer without chemo. Now, who dares to do that? There's almost nobody who wanted to do that. They did it. And they did 2 studies, one with nivolumab plus relatlimab during 8 weeks, and then excise the primary tumor, and they get about a 50% pathologic complete response rate and a major pathologic response rate of 73%. For the nivo-ipi, anti-CTLA-4, anti-PD-1 combo, they get lower percentages, but they waited only 6 weeks. So for me, this means just wait with your surgery a little bit, because everything that's a pathologic near complete response will already then further convert to a pathologic complete response in the additional 2 weeks. So that's another message that we will need to honor all those pathologic major responses by just waiting a bit with our surgical procedures. So lung cancer, I will skip because it was a fantastic talk by Tony Mock. But just to remind you, we have already 4 approvals of neoadjuvant immunochemotherapy in lung cancer, with here the overall survival benefit in the pembrolizumab trial and an overall survival benefit with the nivolumab anti-PD-1 trial. And so that is now, as he showed in so many ways, the way to go in lung cancer. Now, gastroesophageal junction and gastric cancer is a little bit more difficult. So there is neoadjuvant immunochemotherapy in trials. The Matterhorn trial was reported at ESMO last year. And what was the outcome? You see, there's an overall survival benefit, but it's much smaller. So in gastroesophageal junction and gastric cancer tumors, it is not as spectacular, but it's still significant, the benefit. Now, the poster child of avoiding mutilating surgery is colorectal cancer, is the rectal cancers. And we had a great talk about this, about what's happening here. But you cannot program patients anymore for colorectal cancer surgery without knowing if they are match repair deficient or match repair sufficient tumors. Because if they are match repair deficient or MSI-high tumors, wait a minute, no planning of surgery. You go and give them anti-PD-1 or preferably anti-PD-1 plus anti-CTLA-4 combo. So you work then with the primary tumor, which is loaded with T cells to expand all those T cell clones. It's your best chance for cure. And this Miriam Chalabi data, it was already shown. You see, they, in essence, 95% all get a pathologic complete or near complete response. In the dostarlimab trial, anti-PD-1 alone, all major pathologic responses. This is the combination of anti-PD-1 plus anti-LAG-3. Look at that. Exactly the same thing. So meaning that these tumors should not have surgery first. They should have immunotherapy first, and then only surgery if still necessary. So you can follow your rectal cancers by biopsies and by MRIs, and you can avoid rectal cancer surgery at all in these patients. So then what about the MSS, the proficient MMR tumors? Well, there's very interesting data emerging with a genus neoadjuvant bot-bal. Bot is their Silimab is their anti-CTLA-4 molecule, which is the best anti-CTLA-4, I think, right now in the world. And bal is a regular anti-PD-1. And they do it in colorectal cancer. Look at here. So look at the three effects. With blue, it's just anti-CTLA-4. In red, it's the combination of anti-CTLA-4 plus anti-PD-1. And in yellow, it's the MSI-high tumors. And so you're not surprised they all have a pathologic complete response. But look there in the middle. These are MSS colorectal cancer. So this is going to change the world because also standard proficient MMR colorectal cancers, if you work with the primary tumor and the lymph node metastases, are quite sensitive also to neoadjuvant immunotherapy. So follow this closely, and I guarantee you it will change colorectal cancer approaches. And then bladder cancer. So who in the audience would like to have a radical cystectomy, urinary bladder cystectomy? I see no volunteers. No, of course, nobody wants a radical cystectomy. So how can you avoid it? Well, it has a very high tumor mutational burden, bladder cancer. So it's demanding neoadjuvant anti-PD-1 based treatments. And of course, it's true that again, the adjuvant anti-PD-1 is not sufficient. Look at the right curve. There is no overall survival benefit. But when you go to the neoadjuvant setting, hey, you all of a sudden have with durvalumab and neoadjuvant anti-PD-L1 chemo, you have an overall survival benefit, and you have the overall survival benefit here with perioperative and for tumab vedotin as an ADC and pembrolizumab in bladder cancer. And look how big the overall survival benefit is. Of course, it changes completely the treatment in bladder cancer, and it saves 50% of patients a radical cystectomy. They don't need a radical cystectomy. So these are the last two slides to show you that even in a tumor type that we think nothing can be done, right? You know, glioblastoma. So this is Senator McCain, this is Senator Ted Kennedy, and some of your friends. We all have lost friends to glioblastoma, and they usually die within 2 years of the first diagnosis because primary surgery is never radical. Then you get the relapse and they die. So what did they do at UCLA and UCSF, University of California, San Francisco? They randomized 20 versus 20 patients with a relapsed glioblastoma, and they're all programmed in 2 weeks for the resection surgery. So there was time for only one dose of preoperative anti-PD-1. These are the red curves. The blue curves, they got placebo. There's significant impact on progression-free survival and on relapse-free survival. And there's even an overall survival benefit. They got the resection specimens of all these patients. This is in Nature Medicine. And the tumors that had seen anti-PD-1 in that 2-week time frame before the surgery were full of lymphocytes. And the patients who had received placebo, there were no lymphocytes in the tumor. So even these so-called impossible tumors are asking for neoadjuvant immunotherapy. So the new paradigm is triple benefit with neoadjuvant immunotherapy, more cures, shorter treatments, less surgery. And so the message is immunotherapy first, and then, immunotherapy first, and then immunotherapy first. Thank you.